Okay, thanks, Shuyin. So today I'll be talking about how we get this difficulty seeing things up close as we age, and what's the main reason why we have this, and some of the options that we have and we can take. So without further ado, so near vision is a very important aspect of our daily life, be it work, from the time you wake up to the time you fall asleep, especially when you're looking at your mobile devices, looking at the computer. All this kind of involves near vision in one way or another. And this loss of near vision that we do get with time is basically known as presbyopia. So I will talk about why do we get this presbyopia condition and what are some of the odd condition, how we can manage this condition in our daily life, and also explain why others are able to manage without glasses and what kind of procedures they have done that allow them to be free of reading glasses. So firstly, we are able to kind of accommodate to near and distant objects, so to speak, in terms of focusing when we look at something at a distance, and also look at something near. So when we lose this function, it is a condition known as presbyopia. And this focusing mechanism in the eye is kind of undertaken by the ciliary muscle and also the crystalline lens. To kind of show it clearer, when we look at something far away in the top left, basically the lens and the ciliary muscle will kind of interact to focus the image clearly on the retina so that our brain can kind of interpret a clear image. Once we look at something near, for example, looking at our mobile phone, the ciliary muscle, the lens will kind of interact again, changing shape for the lens so that we can focus on the image kind of clearly on the retina. If you look at this video file here, where is an ultrasound recording of a live patient, you can see that the ciliary muscle, which is being highlighted here, will kind of contract. This kind of causes a change in the thickness of the lens. The anterior part, or rather the front part of the lens and the posterior part or the back part of the lens will kind of change shape, allowing the focusing of the image onto the retina accordingly. Unfortunately, this function, with time, we kind of lose it. Studies have kind of shown as early as in the 20s, we start to lose this function, kind of culminating in the maximum at around age 40 to 50, which is why during this kind of age group is when we kind of experience the presbyopia effects the most. And this generally is manifested by us kind of bringing objects either one further or closer to our eyes. And also we might even experience eye strain, kind of discomfort or mild headaches towards the end of the day after a long day at work, where we have to use the computers, read documents, or engage in kind of a lot of near activities. So the options generally, what we are most familiar with are glasses and contact lens. And in glasses and contact lens, they kind of function on the same principle. If you look here, the glasses have different zones which kind of help us to look at something which is far or something, an object which is near. Similarly, the contact lenses also have zones to help us focus on the different objects at different distances. There are other treatment options. This kind of come in the form of either one, eyedrops, which is one of the latest approved treatments. There's also laser refractive surgery. And lastly, cataract surgery, which can kind of address some of the issues associated with presbyopia. However, if you look at all these options, it does not address the main problem, which is actually a loss of the accommodation, which means they do not treat the underlying cause. So as I mentioned earlier, some of us can kind of do without reading glasses or even glasses for distance, and they generally can function quite well. And one of the main reasons why they can do this is actually what a kind of a treatment strategy that we use, what we call monovision, where we kind of have the dominant eye be able to see well for distance, and then the non-dominant eye for near. And we can do this monovision treatment strategy in either one, in terms of the laser surgery, in cataract surgery, or even contact lenses and glasses. These are also possible. But as I mentioned, it does not treat the underlying condition, which is loss of accommodation, which means there are compromises to be made. So firstly, I'll talk on the eye drops. This is one of the latest FDA-approved treatment. Basically, it helps to enable patients see near without much loss in distance vision. As I mentioned, there are compromises to be made, which means there are side effects. These side effects do include headache, eye redness, they have burning sensation, and even dimming of vision, and also what we call a myopic shift, which means patients do get a bit of short-sightedness. So if you can imagine, having a bit of short-sightedness means that we can see better for near, but it will affect our distance vision. Okay. So although the results here do require some interpretation, but in short, if you look at these results, there are patients who don't experience this effect, which means there's only like 31% of patients that were given the eye drops actually do get better reading vision. And then in a further follow-up study, they also show that not all patients will experience this increase in near vision. And like I mentioned, although there are an increase in reading vision, they will generally experience some side effects, mainly this headache and eye redness. And also some patients will experience this loss of distance vision. So moving on, laser refractive surgery. It does refer to the group of treatment options which operate on the cornea itself. So what we do is we can correct the refractive error, so to say, by adjusting the degree on the eye, by reshaping the cornea to treat long-sightedness and short-sightedness. So one important thing to note is being short-sighted, such as being maybe 100 degrees to 300 degrees short-sighted, will allow us to see well for near without any reading glasses. But being 100 degrees to 300 degrees short-sighted means that actually the distance vision will not be as clear. And this is where mono vision will come in. So we generally use a laser refractive surgery to correct the dominant eye to be able to see well for distance, making them close to 0 degree. And then the non-dominant eye to kind of see well for near. But as I mentioned, this mono vision, there are also compromises to be made because some patients who are new to mono vision, they can experience this kind of difference in the vision between two eyes. And also most notably, it can affect the 3D depth perception. So patients with monovision generally are not able to kind of see well or judge depth as well. One of the most significant effect is, for example, if this patient with monovision wants to watch a 3D movie, they might not be able to see the 3D effect even when they put on the glasses, which is provided by them. So cataract surgery, cataract refers to the opacification of the lens in the eye that happens with age. So generally patients will experience symptoms such as blurred vision, they might experience hazy vision, or the vision can become a bit dim, or they might even experience glare symptoms. Of course, presbyopia is also one of the kind of chief complaints. And in cataract surgery, there are indications to be considered. This means that we only will recommend cataract surgery to be performed if there are specific indications that are met. That means there is a reason to perform the cataract surgery. So there are also questions about clear lens extraction, meaning we basically remove the natural lens and then implant a artificial lens, or what we call a pseudophakic lens. And this comes with risks and benefits, because if there are no other condition other than age-related change where we get presbyopia, sometimes it needs to kind of evaluate whether if the risks kind of there are significant benefits that outweigh the risks, so to say. And when we implant the artificial lens, or what we call an intraocular lens, this intraocular lens can be adjusted to kind of target the near, intermediate, and also the distance vision. So in such lenses, we basically use a multifocal lens or a extended depth of focus lens in comparison to a monofocal lens. In a monofocal lens, this kind of lens will allow us to either see only for near or for distance. And correspondingly, if we can see well for distance, then the near vision will need reading glasses. Some patients will choose to see well for near, so we will make them slightly short-sighted or myopic, which means that being myopic they will need glasses for distance. So in the multifocal or extended depth of focus lens, as you can see here, how it works is that it kind of uses this different zones, and which is kind of reflected in the rings around here to basically split the light. So we basically focus the light from different distances, from near, intermediate, and far. For example, 100% of the light that reaches the eye, we might use 25% for near, 25% for intermediate, and maybe 50% for the far. And the main aim here is to maximize spectacle independence. It does not guarantee no spectacles required, because some patients who, despite having a multifocal lens, they will find that in certain conditions or certain font sizes, they might still need some glasses help. And some of the drawbacks of having a multifocal lens include glare, halos, the color and contrast vision may be affected, and patients will also need good lighting for near vision. I think this type of lens kind of needs to be further discussed, especially the expectations of the patients needs to be managed. And also, certain patients tend to do better. It does not work for everyone. So that's something to take note of. So in summary, presbyopia is kind of a loss of the accommodation function for all of us, which happens according to age. The maximum, the maximum function loss occurs at the age 40 to 50s. Some patients, they are able to do much better because they are either slightly short-sighted, or they might not have increased visual needs, which is kind of rare nowadays. And according to their visual needs and lifestyle, this can be managed according to either using eye drops, glasses, contact lens, and surgery, which has to be kind of customized or individually assessed as per patient. And lastly, patients who have monovision, where they have the dominant eye for distance and the non-dominant eye for near, tend to do a lot better. That means they might not need glasses as much. If someone is not monovision already, they can actually try monovision and see how well they take to this treatment strategy via the use of glasses and contact lens. So with that, I thank everyone for the time and also the chance to present here.